Welcome back after the break. So we now have Erin, Dailey board, speaking to us this morning. So she is a US family medicine doctor who specializes in providing care in resource-poor environments. She's worked in a variety of places, Haiti, Uganda, Peru, and she's currently working as in emergency medicine in the Northwest Arctic Bureau. So she's here today to talk to us about her experience as an EM doctor in the Alaskan Arctic, navigating Inuit culture, extreme environments in a low-resource setting where the only way in or out is by plane or snowmobile. Welcome.
Thank you. Hey, all right, thanks everyone for coming. We are gonna just dive in here. Starting with the introduction slide that we just already went over, so I don't need to go there. We're just going to jump into the goals of today, which is basically to go over this framework. So what I decided to do is basically, you guys have heard a little bit about my background for the past 10, 15 years. I've been doing work in resource-limited environments, and what I've seen is sort of a trend of things that will come up when you're trying to provide care for a patient, and how to think through how to provide that care using the Arctic as a case study, okay? So it will mostly be focused on the Arctic, but it really does apply to a lot of different resource-limited environments. A couple things before we do that, some disclaimers, no conflicts of interest. I am not that savvy. The views and opinions are all my own. They don't reflect anybody's opinions except for me. They're not my opinions aren't intended to malign any culture, religious group, club, organization, anything like that. And then I do have some case studies at the end. All the information has been changed, sometimes made up, just to make sure that there's no way to identify any of the patients and they remain anonymous. So, and then one other thing before we dive in is it's really important to do some tribal recognition. So I've been very fortunate to be able to work with the Manilik Association, which is a consortium of about 12 different tribes located in these villages now. And who they are, so Inuit, which is like a circumpolar population of people. And they have kind of these different tribes within that, and in the Northwest Arctic Bureau, they're known as the Inupiat, or the Inupiaq. There's like a couple different ways to pronounce it and say it. So I was working specifically with that group, and then within that group, there are different tribes because these villages are made up of extensive family systems. Traditionally, they're semi-nomadic and sustenance livers, hunter-gatherers. And they've been there for like 14,000 years. So Point Hope, which is one of our villages, is one of the oldest continuously established lived-in village in all of North America. It's been there for about arguably between 10 and 14,000 years. And a lot of their sustenance living practices still continue to this day. There's a lot of net fishing. The picture below that is of them drying their fish. They have the most beautiful embroidery skills. Like, Patagonia's got nothing on them, okay? You want to stay warm and protected, and you can get an elder to make you something, you will be solid. The picture below this is a blanket toss, which is, they mostly do at ceremonies, and this is at the Whaling Festival in Point Hope. That's how they would traditionally view or see caribou herds. So it's very flat up there, and to sort of get a better view of what's going on, they would do those blanket tosses. Sled dogs, of course, big thing. It, like, way up in the front is my rescue puppy, not pulling at all. And he's a rescue. Typically, it's more recreationally now as we've transitioned to snow goes. And then that's me with my one of my little dolls that one of my patients made me. So a really, really amazing tribe, and I just, give them recognition. I'm very grateful to have been honored to be able to work with them over the past several years. So here's our little framework, when we're dealing with any population, in my experience, the first thing that's always really important to figure out is you've got to think through a couple of things. And every time you think through one of these points, you're going to be like, I continually ask myself, okay, what are my resources? So starting with location to get an idea of like, why does location matter? Why do I have to start there? For size reference and distance reference, here we've got a picture of Alaska that's overlaid over the US, and you can see it pretty much stretches from coast to coast. The orange outline is the UK. So just in reference to what kind of implication that'll have on how you manage your patients. That star is where I was working at in Kotzebue. In Alaska, in these boroughs, what'll happen is you'll have a hub where your hospital is, and then in that borough, it's the only hospital that'll be there. The Northwest Arctic Borough is a little bit bigger than Scotland, and it's got 11 different villages. The entire population is about 7,500 people. And so all of these villages will be calling into you and running patients by you, and you're going to have to figure out how do you treat these patients. Do you treat them there? Do you ship them out? Do you ship them to you? For context, that little tiny star right there is the nearest level 1 trauma center. Okay, it's about 580 nautical miles from my hospital, so it's quite a stretch. There are no roads between those two stars. So you're going to be flying someone out. The Anchorage, unfortunately, does not have all the specialists. They have most of them, but not all of them. So sometimes the nearest specialist is going to be Seattle, and that's a 2,000 aeronautical trip, which is like sending someone from here to the capital city of Jordan, about that same distance. So just to give you a context of why location matters, because you're going to have to start processing through all of this information as you're thinking about your patient who's calling in. The other thing about location is the environment, right? So are you working, is your patient actually in town? Are you working in the hospital in the middle of a blizzard that's going to knock your, any movement in or out of your area for 3 days? It's super common for that to happen. Last year we had like a series of about 3 different blizzards that just back to back to back. It's stressful. Is your patient out in one of the villages? These villages are super remote, that's one thing. And then also, sometimes like this particular village, they had an issue in the middle of February a year or 2 ago. All their pipes froze. And that was it until things thawed out. So things can get really tricky. They had no running water. And you have to be able to think and compute that when someone calls in with an issue like a cellulitis and you recognize that they don't have running water, that changes your management of that patient. Also, sometimes you get flooding that'll knock out your runway in. So sort of understanding the different dynamics in these villages and the environment that you're in, and is there weather coming in? Do you have running water? Things like that will also play an important role. Chief complaints. Okay. It's great when we're learning medicine, right? Because we get these really clear chief complaints, and you're like, patient has this. You're like, excellent. If only it were that easy, right? Anytime you go to a different population, anytime I go to a different population, I always try and do a little bit of research about the epidemiology of that area, because common things are common except kind of not, right? So it depends on where you're going, because the prevalence of diseases are going to be different depending on where you are. And then communication skills. So to dive a little bit deeper, like I said, common things are common, but they're different prevalence depending on where you are. In my experience, a lot of the prevalence is driven by environmental reasons, population genetics, and social pathologies. So things like traumas. So if you're working with a population that doesn't really get a lot of sunshine and they don't get a lot of vitamin D, I promise you they're almost all vitamin D deficient. And I know we've got all these studies about vitamin D going on right now. But if you have a lifelong history of not enough vitamin D, it might affect your bones. So in my experience, anecdotally, because there have not been studies on this, they are a little bit more brittle. This is an X-ray of someone who tripped. Can anyone, I don't know if anyone can recognize what's going on there. Can you see that? So this was a gentleman that was under the influence, and that may have, I don't know, may have had some impact on it. Tripped, hit his head on the edge of furniture, and almost had a near internal decapitation. So that's a fracture of the C2. His right vertebral artery was completely occluded. And that was just from a fall. That was from a fall inside a home. So don't ever if you ever work up north, don't ever underestimate, I fell. I fell and I have a little bit of pain. Okay, get an X-ray. And P.S., whatever village they're in, you're not going to have an X-ray machine. So you're going to have to figure that out. Skin infections. Strep is angry up there, okay? I mean, seriously angry. Sorry, that's going to be up for the rest of the slide. So I never take skin infections lightly up there. If someone's got strep, it can spread so rapidly, drop someone in sepsis, necrosis, all that kind of stuff. Bacterial meningitis. I mentioned strep is very angry up there, right? There's a lot more prevalence of bacterial meningitis, so it's something that you have to keep in mind when you're dealing with kiddos with fevers or, signs of meningitis. I put cold water drownings and severe frostbite in parentheses because these are still low frequency things. You'll see them. To be fair, everything up there is low frequency to some extent. But cold water drownings, their prevalence in Arctic or Alaskan Native populations is over twice that of the lower 48. A lot of that has to do with where they live, ice breakup season, their lifestyle. It's great if you can learn how to swim, but if your only option for learning how to swim is the Arctic Ocean, that can be a little bit of a limiting factor. So we do see them and frostbite. So if there's one thing they know how to do, it's protect themselves from cold. Okay, so really you don't see a ton of it, but when you do it, it's because something went wrong. Okay, and when something went wrong in negative 30-degree temperature, it's going to be really bad. So the frostbite that I would see, I wouldn't see it every day. It would be, people were losing limbs. Population genetics, CP2A deficiency. I'm just going to assume that nobody knows what that is. It's okay if you don't. It's CP2A Arctic variant is what it is, and it's a deficiency in a liver enzyme that inhibits your ability to metabolize fatty acids. Why that's important, okay? In kiddos, less than 2, if they stop eating, they stop being able to produce glucose, okay, which can drop them into hypoglycemia, which can then lead to death, right? So what do kiddos do when they get sick? They stop eating, okay? So any kid under 2, if they're sick, one of the things you have to be thinking of is checking to see if they have CP2A deficiency. So many of them do. And then if that's the case, mostly you have to think about, are they eating? And if they're out in the village and they're not eating and it's just a mild fever, it doesn't matter. They got to come in. Septo-optic dysplasia is more common in this population. Rheumatoid arthritis is so prevalent. Ehlers-Danlos is up there. It's interesting that it's not like an Inuit or Arctic common thing, but there's a family that has it and it is genetic, and so you just see a lot of it because these families are quite large. And that, if you want to get nervous, bring in a pregnant lady with some abdominal pain with Ehlers-Danlos, because, I don't know, scary things. Social pathologies, we all have them, okay? Every culture has them, right? Whether it's meth, whether it's heroin, what have you. The flavor that we see up there is a lot of alcoholism and depression. And that's just know what you're walking into, get used to treating DTs and overdoses and stuff like that. So understanding your epidemiology before you walk into a new environment is never a bad move. Communication skills, cultural fluency, right? I really break this down into 3 different things: verbal, body language, and the big thing, emotional fluency. So verbal fluency, pretty straightforward. They do have their own language. It's not hard. Let me see. Halu givsik. Everyone say that? Just say it. Halu givsik. Nice, you just said hello. So it's not hard to do. It's like one word. It can go miles with your elders, okay, that still speak it. A lot of the younger ones, they speak English predominantly. Occasionally you'll get an elder that does not speak English, and they'll have to come in with a family member to help you navigate their presentation. So it's always nice, even if you can't master the language, just one word really goes a long way. Body language fluency. So they are very stoic, okay? And that can be really hard for me to interpret, and it has been. I had this conversation with this 12-year-old boy where I was asking him, all these questions. He kept raising his eyebrows. I kept on thinking like, oh, he's confused, right? Nope. After about 5 minutes of me reframing the question, the mom stopped me and she's like, "You don't know what that means, do you?" And I was like, "Oh, it means he doesn't understand it." She's like, "No, that means yes." So he was nodding his head to all of my questions as I continually rephrased it. And I was like, "Oh, there you go." Once you learn some of these body language things, ooh, your interviews can go so much faster because they are not big talkers. Okay, but they do raise their eyebrows to let you know, yes, they're not going to not. So remembering that body language changes from culture to culture is good. And then emotional fluency. So understanding stoicism in that culture is really important. If you've got an elder and you're asking them if they have belly pain and they're like, "Oh, it's not too bad," be worried. So, take their report of their pain and their experience. It's maybe with a grain of salt. And then for them, family history is so important. It is how they introduce themselves. My introduction to this group was all based around what I've done. Right? Didn't mention who my parents were, didn't mention who my grandparents were. That's not how it would roll in the Arctic. If you do your introduction in the Arctic, you start with who your grandparents are, then you go on to who your parents are, and then people know you, and then you can have that conversation. I had a 20-minute conversation with an elder, and I just couldn't get her to open up, and then I started talking about my grandma, and bam, floodgates opened, just like that. So understanding those little cultural cues, really, really helpful. Because getting an accurate chief complaint is really important in combination with your location for the next step, which is trying to figure out if you can treat that patient remotely. So whether that remote treatment is in the hospital, awesome, because then you can see the patient. A lot of times it's not. So a lot of times they're out in the village, and you have to figure out, can I treat them there? And so what I do is I always run through this sort of 3 questions, very simple. Who's out there? Is it a village health aide? Is it an advanced practitioner? What can they handle as far as patient management? What is it fair to ask them to do? A lot of your health aides, so Village Health Aides is a program that got started in Alaska in technically the 50s with tuberculosis, but formalized in the 90s, where they train native villagers that live in the village to provide some amount of health care. It's a, a 4-month program that gets extended to 2 years with some clinical check-ins. So it's not a lot, but it's so helpful. And these village health aides, they're your eyes and your ears and your hands. They're godsends. But also, they are the only people there. They are on call all of the time. Your health aide may have been up all night working with a patient. They may be fatigued. Most likely they are fatigued. So sort of understanding that you have a resource and respecting that that's still a limited resource. Sometimes there's an advanced practitioner out there, but not always. So understanding who your personnel is, what's their capacity, respecting their limitations. understanding what your diagnostics and pharmaceuticals are. So in the villages, you basically only have point of care labs. And the pharmacies out there, they're limited. Health aides can't push IV meds, so they're not going to be giving, they're not going to be running code, not going to be doing a lot of things like that. So, and then some the pharmacies in the villages run out of things, and you just have to learn to deal with that. And then, of course, there was no imaging out there. And even in the hospital, where I, like the big hub for the center, we didn't have an MRI. So all we had was an X-ray and a CT. And sometimes our CT went down and we didn't even have that. We usually had ultrasounds, but sometimes our ultrasound staff got weathered out or sick, and then we didn't have that. It was all up to you. And that sort of goes into equipment, which is to remind yourself that you can have the most bomber medical personnel in that village, and maybe you've got a patient that's coding, they just need to be intubated, but there's no ET tube, or there's no glide scope. So it doesn't matter how good your medical staff is, if you don't have the equipment to support them, nothing they can do, right? So all of these things are going to factor into your decision about, can I treat that person out there? If you can, great, keep them out there, ideal, because your entire population is running on limited resources, and you have to use that resource wisely. So anytime you use a plane to get a patient out, the entire area has one less plane. How many planes do you have for your area? One, right? One local plane, and then you've got other ones that are further away that you can use, but they're further away. It's going to take a little bit longer, and sometimes everyone's using them. You don't have a lot. So if you do treat them remotely, it's just important to remember to continue to circle back in and continue to check in until you can either send them home, they're better, or they come in, okay? So let's say you cannot treat them remotely safely. The next thing you're going to have to think about all at the same time are these three topics, which is how do you stabilize that patient in a limited resource setting, how do you transport them, and where are they going? So for stabilization, same questions that I'm running through. What's my personnel? What are they capable of? What are my diagnostics? And what's my equipment or lack thereof? So if I've got a patient, for example, that is not breathing too well, was found unresponsive with bottle of alcohol next to him, O2 sats in the 70s. Our O2 out there might go up to 4 liters, and you're still not getting really good O2 sats on him. And sometimes putting them in a semi-Fowler position where you can get the weight of their chest off of their lungs when they're in an alcoholic coma can help, because what is happening is they're losing control of their muscles, right? And so they're not able to use their muscles very well to move the lungs in order to get air in. So you start using body position instead of the intubation that otherwise you would have done. So getting creative with how you manage these patients and learning, what you can do and not do. And also take care of your team, right? Because you're on the phone, but they're next to the patient. And they're the ones that are having to hold their hands and be there as this patient is crashing. So, and then also you have the option of sending in resources. So if someone's really crashing and you have to send a plane to get them, put stuff on that plane, right? Get it to them quicker. Okay, transportation, what that looks like. So it's the same questions, personnel, all that kind of stuff. This is a little sample of options that we have in the Arctic. We've got, and it's helpful to know your planes. So we've got a Cessna 208. This is our commercial option, because you always have the option of bringing people in commercially. Our 737 Alaska goes to Anchorage. We've got, what is this? We've got the King Air and the Learjet. Okay, the Learjet comes out of Anchorage. Your King Air is going to be local. They all have different flight speeds. It is helpful to remember that when you're thinking about moving these puzzle pieces around. Sometimes you'll have multiple calls where you need to get multiple patients out at the same time, and understanding, okay, I've got this plane that can go this fast, so I'm going to send them to this village while I got this plane coming here, and I'm going to use this plane to go here because they're faster. It is really, I'm not the best at it. I think it takes serious mental gymnastics to try and figure that out. But it's important to know. And then, I threw the snow sled up because we still use it in Kotzebue. But if you ever bring a patient in by snow sled, thank the EMT that rode in that with them because it's cold. So also with your different air services, as far as personnel goes, we have like 2 different crews that we can call from. One does not manage neonates because they don't have the personnel or equipment to manage neonates. Knowing that is huge because if you activate the wrong air service, you can delay care for quite a bit. We also, I noticed we've got some coasties, have the Coast Guard during part of the year. Typically, we don't have you, but it's amazing when you do, and the Coast Guard are amazing and will come help during times, at times. And then also the weather. Weather is so huge. Anticipating weather, sometimes whether you bring a patient in or not will revolve around, okay, I've got a storm front coming in. I don't really know if they need to come in, but if I don't bring them in now, I'm not going to be able to get them in for 3 days. So you bring them in just to be safe. So that's transportation. And then destination, run of the mill. We all know this, right? So anytime you're working with, you're moving a patient, you want to think, where's the best place to send them? A lot of times, most of the time, it's going to be to the hub hospital so they can get worked up, evaluated, a formal diagnosis, and then shipped on to wherever they need to go. Occasionally, there's no point. Occasionally, they just need to go straight to Anchorage. It takes a lot of maneuvering and acceptance and, friendly doctors to accept them straight from the village. But if it's very obvious that there is nothing that I'm going to be able to do to help this situation, you can send them straight there. Okay, so that's sort of a rundown, all right? And what we're going to do now is we're going to start with a case study. And I'm going to ask for people to get involved. I have no idea who's in this room. But we'll just see how this goes. So you get a phone call, okay, saying that you've got a patient in Norvik. 62-year-old male presents to clinic with sudden onset severe right lower quadrant pain and 1 episode of emesis. So we're going to have our little algorithm up there. Who wants to start us off? Can I just get an idea? Do we have nurses in here? Raise a hand. Do we have doctors in here? Nice, wow, okay, cool, all right. Okay, advanced practitioners? EMTs? Sweet, okay, all right. Okay, so what information, does someone want to ask another question? What information do you want to know? More information. Anyone? How far away is he? So this gentleman is going to be in Kivalina. That's about a 35-minute flight. Kivalina is not experiencing, well, actually, yeah, Kivalina's fogged in right now. Okay? So your commercial flight is a no-go. All right? Other questions? Yes? Is he stable? How would you assess that? Is he stable? What a great question. What do you want to know to find out if he's stable?
I guess there's an ATE being done. Do we know his ulcer?
Vital signs? Is that what? Yeah, vital signs. Let's look at his vital signs. So vital signs, no fever, blood pressure a little high, right? Heart rate 99, not terrible. Breathing okay. So yeah, he looks pretty stable. Severe pain that caused emesis. Yes?
They've got a point of care, got an ISTAT or a urine analysis?
No ISTAT. You do have a UA.
Has he got blood in his urine?
He does have blood in his urine. Okay?
Ultrasound.
We do not have an ultrasound.
Did he have blood in his emesis?
No blood in his emesis. Good question. Yes.
Who's the healthcare provider on site taking care of him?
You've got a health aide.
What does that mean?
That means that you've got someone who's really good at information and assessing the patient. Okay? All right, yes.
Confirming it's not trauma-based, and does he have a history of this?
No history of this. He was doing fine, just all of a sudden, severe right lower quadrant pain, no trauma.
What's his abdominal exam?
He's got severe pain. He's like screaming and writhing, okay? Does not want to be touched. Looks like, dare I say, an acute abdomen. Okay. Yes.
Any like testicular or groin involvement?
No testicular involvement. I'll say that. Yes. Yeah.
We asked about if he's had previous episodes, but what is his past medical history?
Excellent. Past medical hypertension. That's all you got. Yes.
Point tenderness or rebound tenderness?
Both. Okay.
Referred up to either the shoulder blades?
No. And past medical history, I'm a surgical history, right? You want to know that? Surgery? Yeah. He's had an appendectomy before. Okay, so no appendix. Okay.
What are options to get this guy a bit more comfortable? Can we...
Nice.
What else easier?
Yeah, you got T3s. So that's,
What does that mean?
yes. What does that mean? You don't know what T3s are? That's, like, you guys say a paracetamol, right? Acetaminophen and codeine. Okay. And ibuprofen. So, yeah, absolutely. So you want to give them some pain? Great. Okay, so you give them 2 T3s. That's a standard dose. And, yeah, anyone else? Let's stop there. Do you want, so like, who's ready to decide if they can treat him remotely or whether he needs to come into your hospital?
You cannot treat him remotely.
Awesome. Yeah. Okay, no, you can't. Okay. You don't want to leave this guy out there. So he is going to come in, all right? Your commercial flight's not a go. The next question is, do you want to use your local crew or an off-base crew?
Where are you going?
You're going to your hospital, okay? The benefit of a local crew is that they can get there faster. What happens when you use that resource is if there's a trauma or anyone bleeding out, it takes them that much longer to get to them.
Understood when I kept saying not a local crew.
Yeah.
This guy doesn't smell time critical.
Yeah.
And I don't want to strip away the local crew.
Nice move. Nice move. I like it. So we're going to use an off-base crew. We're going to go faster, too. So you use off-base crew. You get them to your hospital, and I'm just going to run through some things. So I have learned that our units are different. Ironically, on an in-flight emergency here, where someone told me their blood sugar was 30, that means totally different things in the US than the UK. So these are US units, but basically the interpretation of this is his kidneys are crap, okay? Kidneys are totally trashed. Sodium's fine, potassium's fine. We're gonna go there. His CVC, nothing too bad, okay? Like little off, but nothing scary. His UA, a lot of blood. Anyone want imaging? Great. We're gonna get imaging. We've got a CT. What is that, right? That is his bladder, okay? That's his bladder. And those are his kidneys, okay? So, and just because we're gonna fast forward through this, the next thing that maybe you would want to do is decompress, which is what happened. At that point, you have to decide, do you keep this patient in your hospital or do you send him elsewhere? It's just you, okay? There's no surgeons, there's no specialists, there's no nephrologist, there's no urologist, nothing, okay? So it's just you. He, spoiler alert, got shipped out. Thankfully, because he then proceeded to have a hemorrhage requiring a massive transfusion protocol. He got 12 units of blood because when you rapidly decompress a bladder that big, you can get a lot of bleeding. And in this particular case, it was a lot of bleeding, which was really good because our hospital only carries 6 units of blood. So it was really good that he got shipped out. And what caused it? Just the prostate. No cancer, just an enlarged prostate. And I would add to that enlarged prostate with not adequate access to primary care. okay? Because this could have like very easily been preventable. So the other cases, like, you know, sometimes you'll get a self-inflicted gunshot wound to the abdomen and they're out in the village, okay? How do you manage that? Because you're going to get that phone call, okay? Sometimes you're going to get, not sometimes, but not infrequently, you'll get a phone call where you have your crew doing CPR and you have to manage and run the code from a phone with no eyes, okay? And they want to know what to do. And you have to figure out how to direct CPR without being able to see anything. So tie your hands behind your back, put a blindfold on, and have at it. Okay, that's good. Yeah, I made it. Okay.
Thanks very much, Erin. So yeah, whose heart rates are up based on those kind of cases and how you might deal with them? We've only got a couple minutes, I'm afraid, but open to the floor. Any questions from anybody here?
How's the healthcare system funded, and do you find budgetary constraints significant compared to kind of the resources you've got?
Yeah, so the question was about the healthcare system funding in the US. That's a good one, right? And does it cause restraints? So this healthcare system is funded by the IHS, which is federally funded, which is amazing in the US because I don't have to think about it. I don't have to worry about people not coming in because of insurance. I don't have to worry about insurance not covering something or authorizing something. That is not an issue at all, but only because it's with an Alaskan Native or a Native where it's all federally IHS funded. Any other questions? Yes.
Just quick, thank you very much for that talk. Interesting similarities to our Maori people in New Zealand. But a couple of quick questions. Do you ever get involved in any of their traditional medicine and incorporate that into your management? And secondly, what sort of standard care for severe frostbite?
Okay, so the first question was about traditional medicine. Do I get involved in man, I like geek out about traditional medicine. And I always encourage patients to tell me about it because I've got one patient that came in and once they realize that you're open to discussing that and incorporating it, you'll get a lot more information like, oh, I've had stinkweed on my leg for the past several days and this, that, and the other. Or they do a lot of body manipulations as well. They do have traditional healers. I've been fortunate enough to talk with them. There's used to be a lot more involvement of traditional healers in the hospital, directly, where they'd have an office next to the Western medicine. They're thinking about bringing that back because I think integrating that is always good. I don't know if that answers your question. One. Question two was about severe frostbite and what that looks like and what that management is. So the first thing is recognizing it because when it first happens, it's not super obvious, just a little dusky, right? You gotta warm it up. And that's tricky, right? Because you put those ice cubes in warm water, can't be hot, and the ice cubes cool the water down pretty quickly. So you have to constantly sort of renew that bath. You push TPA if it's been within 24 hours of thawing, okay? Not 24, so if you've got a patient who's been frozen for 3 days, I had one patient once that was frozen for 3 days, okay? Came in, it was still okay to push TPA, even though it had been 3 days since the onset of symptoms, because he did not thaw until within 24 hours of him presenting. And then, yes, ship him out. And you're talking to the specialist, the ortho in Anchorage the whole time as well. That's kind of...
TPA is your mainstream.
Yeah.
Calcium channel blockers right now.
If you look at the Alaska Cold Injury Guidelines, it's really... TPA is your big gun. We start ibuprofen, and that's generally it. Aloe vera for pain management. That's where we are.
Thank you. We are going to have to stop here, I'm afraid. Any more questions? I'm sure she will be available.